What are the challenges of urine cytology in bladder health? Urine cytology is a test that looks at cells shed into the urine to help detect bladder cancer. While it is a useful tool, it faces several important challenges that can affect its accuracy and usefulness. One major issue is its limited sensitivity, especially for low-grade tumors. It can detect about 40 to 55% of bladder cancers overall, but it is much less effective for low-grade tumors, catching only around 10% of these cases. This means many low-grade bladder cancers can be missed if urine cytology is used alone. It tends to perform better with high-grade tumors, with sensitivity around 50 to 50%, but still leaves room for missed diagnoses. Another challenge is that urine cytology has high specificity, meaning a positive result usually indicates cancer. However, because its sensitivity is low, a negative result does not rule out cancer. This can lead to false negatives, where cancer is present but not detected by the test. Because of this, urine cytology is often used alongside other diagnostic procedures, like cystoscopy, which allows direct visualization of the bladder. Cystoscopy remains the gold standard for diagnosis and monitoring, since urine cytology cannot replace it. Interpreting urine cytology results also involves a lot of subjectivity. The test relies on pathologists examining cells and making judgments about their appearance. This can lead to variability between different observers, with results sometimes labeled as atypical or indeterminate. Such variability can make clinical decisions more complicated and may lead to unnecessary biopsies or additional tests. Differentiating benign from malignant changes in urine samples can be tricky too. Inflammation or benign conditions, especially in patients who have had bladder treatments or instrumentation, can cause cells to look abnormal. This overlap can produce false positives or indeterminate results, which may lead to unnecessary procedures unless additional markers or tests are used to clarify the findings. Urine cytology also cannot stand alone as a diagnostic tool. Despite being non-invasive and easy to perform, it cannot replace cystoscopy, which allows doctors to see inside the bladder and take tissue samples if needed. Current guidelines recommend using urine cytology as an adjunct to cystoscopy rather than a replacement. Emerging urine-based tests and biomarkers are showing promise, especially for detecting low-grade tumors that urine cytology might miss. However, these newer tests often have lower specificity, meaning they can produce more false positives. They are not yet standard practice but may help in cases where cytology results are unclear or to monitor treatment response. Finally, practical issues can affect urine cytology results. The amount of tumor cells shed into urine varies depending on tumor type and stage, and the timing of urine collection can influence the results. The quality of the urine sample itself, including how fresh it is and how it was collected, also impacts accuracy. These factors make consistent and reliable testing challenging. In summary, urine cytology is a valuable, non-invasive test with high accuracy for detecting high-grade bladder cancer. But it faces limitations like low sensitivity for low-grade tumors, subjective interpretation, and inability to replace cystoscopy. It works best when combined with other diagnostic methods to improve detection and reduce unnecessary procedures. Always remember, if you have concerns about bladder health, consult a healthcare professional for personalized advice and appropriate testing.